every history has a system. Okay, every case has a system. So the first part of your history is called demography. And what I want you to understand is when you are giving a viva, the examiner does not want to hear all this. So you cannot make any mistake in demography. You cannot miss out anything. If by chance he asks you any question, the answer should be ready. Okay, there should be no thinking. Ready answers. So when you start with demography, this should be done with question answers, if any, in not more than 10 seconds. Please understand, examiner does not have time, nor does he have patience. If you are going to look here and there and do they'll be like, move on, move on. So the way you present is more important than what you present. So all this should be fast, fast. When I say demography, there are 6 components that have to feature in a surgery case. Medicine case, there are a couple more, but in a surgery case, there are 6 that have to feature. First is going to be name of the patient. Then there is going to be age. Then gender. Please don't say sex. Sex is an act. Gender is what it is. It's not sex. So name, age, gender. Then there is religion, occupation, and residence. So Mugdashri, why does the patient's name matter?
Sir, first of all, we have to identify whether it's the same person you're taking the history of,
Okay.
who came.
And any other reason for asking the name? Like why do I ask your name Mugdashri apart from identifying you? That's why I say please sign in with your own name so that I can identify you. Exactly. Again, any other reason?
Sir, to build a rapport and
Very
some
good.
connection.
Very good.
And also to understand the religion in some cases.
Religion to बाद में तुम पूछ ही लोगे. So fixed question, fixed answers. Relevance of name, identification, and rapport. Tuba Tariq, please tell me relevance of age in surgery. Ananya Shetty has given a nice answer. Yes, Ananya, FFF. I hope no F's are directed at me.
No, I think it stands for 40 female.
Okay, so the diseases that you will remember, I gave a very, very nice mnemonic. So the disease that you will remember are fibroadenoma breast. Okay, there are millions of diseases, but you need to remember only 2-3. Fibroadenoma of breast, typically seen in young population, 15 to 30. Don't say young. Okay, I am also young, but I am not 15 to 30. Fibroadenoma breast, 15 to 30. Gallstones, that's the one Ananya Shetty gave. Gallstones are typically seen, the victim is fat, fertile female of 40. So we will just put it as in the age group of 40s, 30s and 40s. That's where you are going to see gallstones. बस 2 ही याद रखो. 1000 बीमारियां याद रखने की जरूरत नहीं. 2 बस हो गए. Okay, Ananya, since you gave that nice answer, please tell me relevance of gender in surgery. Not sex, gender. Gender.
Can I say the same thing again? Female gallstones.
You are using your brains too well. I am impressed. So it's the same. Gallstones are more common in females. That's why that's the victim, fat, fertile female of 40. So gallstones, more common in females. One of you wrote in the chat, appendicitis is more common in females. It's not so. The new edition of Bailey says males have more predisposition. 3:2 is the ratio for acute appendicitis. So let's not put acute appendicitis. Gallstones, females, everybody knows. Most of the cancers in general surgery are more common in men. Most of the cancers, okay, lung cancer, colorectal cancer, they are all stomach cancer, esophagus, all cancers are more common in men, except there are some which are more common in females, which are also seen in men. Yes, Vidhi Gupta, please speak.
So breast cancer is more common in females.
Very good. So breast is seen in men also. There is something called male breast cancer. Any other?
So thyroid.
Yeah, very good. Thyroid cancers. In fact, all thyroid disorders, not just thyroid cancer, all thyroid disorders, endemic goiter, Hashimoto's thyroiditis, Graves' ophthalmopathy, Graves' disease, they are all more common in females. So breast, thyroid, any other? Open to audience. Cancers more common in females, which can also be seen in men, but are more common in women. MCQ है ये, इसलिए बता रहा हूँ. Adenocarcinoma lung, a little too specific. It is more common in females, but then you would say lung cancer, overall more common in men. That's why. So Nidhi, tough one. You can, if you remember it, fine, but otherwise no. Skin, no. So there is one which Ananya should have answered, gallbladder cancer. So gallbladder cancer is also more common in women. And the fourth one, not so important, anal malignancies. Okay, these are the four that you need to know. Asked in MCQs also. Important one that you need to know, more common in females, are thyroid cancers and gallbladder cancers. Okay, so gallstones and gallbladder cancer, thyroid diseases and thyroid cancer, and of course breast diseases and breast cancer are all more common in women. Everything else is more common in men as a rule, or it's equal. Some things are equal also. Everything is not going to be more in men. Before we start with obstructive jaundice, can you tell me what is jaundice? So when I say jaundice, jaundice is going to be, and you'll remember this now forever, it is going to be yellowish discoloration of skin and mucous membrane. So it is yellowish discoloration of skin and mucous membrane. It is due to increased serum bilirubin. So it is because of hyperbilirubinemia or increased serum bilirubin more than. Now older books would give 2.5. Current Harrison gives 3 mg/%. This is given current edition of Harrison, which I have read a bit. So it is more than 3 mg/%. You can say 2.5 bola to bhi chalega. That is also fine. So normal bilirubin, as they correctly said, is up to 1 mg/%. That's what Mansi was saying. But to get icterus, the bilirubin should be more than 2.5 or more than 3. So Mansi, if my bilirubin is between 1 to 3, say it is 2, what is that called?
Sir, icterus.
Icterus nahi hoga na. Icterus happens when the bilirubin is more than 3 or more than 2.5. Yes, Rohan Mehta. Yes, Rohan Mehta from SAID GS. Not hyperbilirubinemia. It's called latent jaundice or subclinical jaundice. So if the bilirubin is elevated more than 1, but I don't have icterus, means it is less than 3. Only when it crosses 2.5 or 3, that's when the icterus is seen clinically. So that is going to be called subclinical jaundice when it is in the 1 to 3 mg/% range. Rohan Mehta, is there any chance that I get clinical icterus in this range of bilirubin? If you have anemia, no, it's nothing to do with anemia. It happens, can happen sometimes in the recovery phase of jaundice. So if I got jaundice where my bilirubin was 5, 6 for whatever reason, I got icterus. If I am recovering, even when it falls below 3 mg/%, I may still have clinical icterus, even when it reaches maybe say 2, 2.1, because it is still bound to the scleral collagen. In the recovery phase of jaundice, I may still have icterus, even if it is little lower than the clinical range. Okay, are we clear about this? Okay. Mugdashri, what are the types of jaundice? Since your case is obstructive jaundice, let us go one step at a time. Types of jaundice.
Sir, pre-hepatic, hepatic, post-hepatic.
What is pre-hepatic?
Sir, I don't. Sir, like due to hemolysis, when there is more unconjugated hyperbilirubinemia, those are the pre-hepatic causes.
Don't call it pre-hepatic, call it hemolytic jaundice.
Hemolytic, okay.
So the one which is seen typically in children is hemolytic jaundice, which is seen in hemolytic anemias or hemolytic disorders. Second one?
Sir, hepatic jaundice like in infectious causes of Hep B, Hep C.
Like hepatitis, viral hepatitis.
Hepatitis.
That is going to be hepatic jaundice. Or if he has full-blown cirrhosis, uncompensated cirrhosis of liver, he will get hepatic jaundice. Tisra kaun sa?
Obstructive, that is post-hepatic.
Right. So why I put this is, please get the perspective first. What is the name of this case? Obstructive jaundice. What is obstructive jaundice? It is a type of jaundice. So there are 3 types of jaundice. The one that comes to the surgeon is this obstructive jaundice. I would not call it post-hepatic. You will realize why. So to understand obstructive jaundice, you need to understand something basic, something anatomical, and that is what is bile and what is biliary tree and what exactly is happening in obstructive jaundice. So Mugdashri, what is obstructive jaundice?
When there is an obstruction to the flow of bile through the biliary tree.
Very good. What is
Or,
biliary tree and what is bile?
sir, bile is what is secreted by the liver and then it's stored in the gallbladder, and it's a type of an enzyme which, I mean,
Bile is not an enzyme.
Not an enzyme, sir. It's to digest the fat and the fat soluble vertebrates.
Bile does not digest any fat. Excuse
Sir,
me. How will bile digest anything?
Emulsification.
Bile
Baking it down.
emulsifies fat. Okay. Kruti Patel, help her.
Yes, sir. So basically, obstruction to the flow of bile anywhere from hepatocytes to duodenum.
Okay. Anywhere from hepatocytes to duodenum.
Yes, because it ends there, the duct.
So if there is a block in the cystic duct, that is anywhere between hepatocytes and duodenum.
Yes.
Will I get obstructive jaundice? Okay, tell me the pathway of bile. So let's go even basic. Where is bile formed? How does it reach the duodenum? So you have a liver. Let's go. Let's teach you like first MBBS first. Then we will reach final MBBS. You have a liver. Now if I take a biopsy of the liver and I see under the microscope, it looks like this. Okay, you would have studied this in pathology, but I think it is relevant at this stage. You have those hepatocytes. You know, they are arranged like this in lobules. ऐसे hepatocytes होते हैं. Then in between, in the middle of the hepatocyte, in the middle of this cord, you have a vein over here. This vein is called Kruti?
Central vein.
Central vein. Central vein will give rise to what is called as hepatic vein. Don't worry, I will show you all of this. And we will do more of this when we do portal hypertension. So you have a vein, central vein. Then you have these liver hepatocytes, the actual cells of the liver, the cells that actually detoxify everything. At the periphery, you have three structures. You have a vein, you have an artery, rather a branch of an artery we are seeing under the microscope, and you have a branch of a duct. These three together is what is called as portal triad. Okay, and what does this portal triad have? It has a branch of portal vein, not hepatic vein, they are different. It has a branch of portal vein. It has a branch of hepatic artery. And it has a bile ductule. Okay, bile ductule, which is a branch of the bile ducts. If I look at the liver under the microscope, this is how it looks microscopically. So what happens is, at this area over here, the hilum of the liver, the hepatic artery, portal vein and bile duct, they are all entering the liver. Technically it's not entering, but for now take it as entering. So the hepatic artery enters like this and enters the liver, gives its branches. Similarly, portal vein will enter, give its branches. So all that blood in the branch will come over here in the hepatic artery, portal vein. From here, it will go in these spaces, which are called sinusoids. Then the liver will do its job. It will detoxify whatever to make the albumin, detoxify, degrade, whatever it has to do, all that it will do to these blood cells. This clean blood, detoxified blood, will enter the central vein. And from the central vein, it will enter the hepatic veins. So there are three hepatic veins. We will study this in portal hypertension. Don't worry about it now. And from the hepatic vein, it goes into the IVC. So blood goes like this. It goes from the hepatic artery and portal vein, enters the liver. Liver will detoxify it and release it in the hepatic vein. So जो hepatic vein IVC blood होती है वो एकदम pure blood होती है. Pure in the sense non-toxic. The toxic part is gone. It's not oxygenated. At the same time, these hepatocytes, whatever they have made as toxic, whatever they have digested, some things it will, whatever is the masala, which cannot go in the blood, that masala is going to become bile and it will enter the biliary canalicula. She used the word biliary canalicula. It will enter the biliary canalicula. So like this, there are many small biliary canalicula. In the small hepatic ducts, the liver has produced the bile and it has released the bile. there are many small hepatic ducts. They keep coming together. Now when they come together, they are going to become two main hepatic ducts, a right hepatic duct and a left hepatic duct. These two will come together and they are going to form the common hepatic duct. This common hepatic duct, so now whatever bile is formed is released in this, is going to enter the hepatic ducts. Then left and right hepatic duct, from this the bile will enter the common hepatic duct. So understand, blood flow enters, bile is exiting. Main difference, bile is coming out. So now bile is coming out in these bile ducts, which have become the common hepatic ducts. This common hepatic duct will receive a duct from here. So this is going to become cystic duct, which is coming from the gallbladder, and these two together will form the common bile duct. Some of this bile goes in the gallbladder and gets stored in the gallbladder. So gallbladder is not producing. It will store the bile so that when I eat, it will eject the bile. Eventually this bile will enter here into the duodenum at this opening called ampulla of Vater. Now when I'm going to say obstructive jaundice, this is what our disease is. When I say obstructive jaundice, there has to be an obstruction somewhere in this pathway, a physical obstruction somewhere here, either in one of the ducts or in the common hepatic duct or in the common bile duct or in the ampulla, but not in the cystic duct. Because see, even if there is a block over here, pathway of bile is not affected, right? Cystic duct blocks will not give you obstructive jaundice. The block has to be in the flow of the biliary tree. So when I say obstructive jaundice, it is jaundice that occurs due to obstruction anywhere in the biliary tree.